Hi, my name is Debbie, and I am obsessed with all things to do with ultrasound. I'm an empty nester who has spent the last 28 years scanning in all different kinds of situations: clinics, hospitals, point of service, emergency departments, private offices, echovascular, general, high-risk OB, and want to dive down deep into all things to do with technology, techniques, and transformation. It's time we take ultrasound to the next level. Think of this like your little power boost on your commute to all things ultrasound, along your way to the thing that we call work. So pull up a seat, make sure you're comfy, and be ready to be challenged and encouraged as we learn it's all about the frequency. Hello. In this podcast, I'd like to talk about the ductus venosus. We will be discussing what it is, what its function, why it's important to the Doppler, the ductus venosus, what do those Dopplers mean, and how to interpret those Dopplers, and what happens to the ductus venosus after the baby is born. So the ductus venosus is divided into two stages. The first stage establishes the ductus venosus as a major vessel in the bilateral systemic arrangement of the hepatic sinusoid. From the yolk sac, blood flow through the omphalomesenteric vein and the liver to the sinus venosus, while the blood from the chorionic villi bypass the liver and empties into the sinus via the right and left umbilical veins. There were a few other doctors, Dr. Dixon in 1956 and Aldostone in 1980, that said that the ductus venosus, the pressure fluctuated a little bit, but could also react passively to ensure adequate venous return to the fetal heart. In 1998 to 2004, there was a Dr. Bellotti noticed that the diameter of the ductus venosus was increased and with growth restricted fetuses. So let's think about the mom who has hypertension or where there's a marginal cord insertion and there's not a good blood supply from the placenta to the baby for some reason. Maybe the placenta is small or any other type of condition where the baby might not get as much blood supply to them as the baby needs. This is why the ductus venosus is important. I also know that I've seen in certain types of heart defects or certain types of defects of the baby where they will put a catheter through the umbilical vein after birth to keep the ductus venosus open for a time while working out the situation of the baby's heart or other complications, and until they can get the baby to surgery to fix that heart defect and to stabilize the baby. So it's a good bypass to have if there's trouble on the way and we need to stabilize prior to any kind of surgery. So let's talk about the location. Where is the ductus venosus located? The ductus venosus is a bypass that comes off the umbilical vein that comes into the baby's belly. The ductus venosus is about 3 millimeters in length and is consistent with a contractile smooth muscle structure. When you put your color flow on the structure, you're going to need to make sure that you turn your scale down in order to really pick up where that ductus venosus is. However, when you turn your scale down, you're also going to have to remember to turn your gain down, as turning your scale down will cause a lot of flash. So you'll need to remember to do that. So when you do this, you'll be able to see the structure that's aliasing. And that, where you see that aliasing is it. That's the ductus venosus coming off the umbilical vein on the way up to the heart, right atrium of the heart. Now, remember, I said it was 3 millimeters. Remember, we're talking about millimeters in this company. So sometimes adjusting your gate size, opening it up just a little bit may also be helpful, but be careful with opening your gate too much because then you're going to pick up some of the nearby vessels in the sometimes you'll need the mom to hold her breath. And so I suggest that when you ask the mom to hold the breath, you also hold your breath so you don't forget mom's still holding her breath. I often tell mom, okay, I need you to hold your breath and breathe whenever you need to. And so I give her that permission. And then I just try to do a little bit more timing of when she's going to take the breath and hold it to try to keep at least her still. We can't really keep the baby still. So once you start finding this and Dopplering this super tiny millimeter structure, you're going to get really good at it. It's not as hard as it seems. So just make sure you're giving yourself grace as you're learning, because it's tiny. Sometimes baby's moving, mom's moving. Even if mom just turns her head or lifts her arm or is trying to take care of a toddler who's running around the room, I mean, that moves mom, so just kind of reminding mom, hey, I need to get this one vessel, but I need you to be really still. So now, how do you interpret the blood flow through the ductus venosus? So it's important to understand that the Dopplers of the ductus venosus usually comes after an abnormal umbilical Doppler result. We don't typically go straight just to the ductus venosus. So we Doppler the umbilical because the baby's small, and then when the umbilical Doppler comes back abnormal, then we go and Doppler the ductus venosus. So most commonly, these Dopplers are because of fetal growth restriction. So when you have an abnormal umbilical Doppler and you proceed to the ductus venosus, the studies report that in the presence of fetal growth restriction, at less than 34 weeks of gestation, the risk for stillbirth is 11.16% in an umbilical. For absent or reverse A wave of the ductus venosus, the frequency of stillbirth is about 20%. But the risk for a stillbirth with a reversed A wave is about 46%. I've experienced physicians that when there is a consistent reversal in the A wave, they kind of start the clock as far as, okay, we only have 24, 48 hours to deliver. So after the presence of a reversed A wave, consistent, absent, or reversal of an A wave, imminent delivery is common. So therefore, it's important to verbally contact and tell someone who is in charge of taking care of that patient about the reversal of the ductus venosus as soon as possible, so that a plan could be made for delivery of the baby. In the second stage, symmetry of the first stage is transformed into the asymmetric definition condition, in which the ductus venosus connects the left umbilical vein with the right hip pedal cardiac, later destined to become that inferior vena cava in the late embryonic and fetal stages. This general arrangement of the ductus and main venosus vessels remains substantially unaltered, unlike some animals where the ductus venosus changes your size or totally disappears before birth. In 1944, a doctor by the name of Barclay postulated that the sphincter of the ductus venosus could control the amount of blood which transverses the liver sinusoid, but that its main function was to occlude the ductus at birth. There's another doctor in 1951 named Reynolds who considered that the function of the ductus venosus was to maintain the pressure in the umbilical vein while it was keeping the umbilical vein from collapsing. He also suggested that besides keeping the umbilical vein distended, that with the constriction and relaxation of the sphincter of the ductus venosus, it acts kind of like a valve, and even in the pressure changes, and therefore were a few other doctors. It acts kind of like a valve, even in the pressure changes. And then there are a few other doctors, Dixon in 1956 and Alderstone in 1980, that said that the ductus venosus and pressure fluctuated a little bit, but could also react passively to ensue aqueduct venosus return to the fetal heart. In 1998 to 2004, there was a Dr. Bellotti who noticed that the diameter of the ductus venosus was increased and growth restricted fetuses. So let's think about moms who have hypertension or where there is a marginal chordae surge or not a good blood supply to the placenta for some reason. Maybe the placenta is small, but any type of condition where there's a possible developmental cord restriction that the baby might not be getting as much blood flow to the baby as it needs. This is why the ductus venosus is important. I also know that I've seen in certain types of heart defects or certain types of defects of the baby where they will put a catheter through the umbilical vein to keep that ductus venosus open for a time while working out the situation of the baby and making a plan, keeping the heart stable until baby can have surgery to fix whatever's going on with that baby. So it's a good bypass to have if there's trouble on the way or we need to stabilize the heart prior to surgery. So where's the ductus venosus located? The ductus venosus is a bypass that comes off the umbilical vein that comes into the baby's belly. The ductus venosus is about 3 millimeters in length and is consistent with contractile smooth muscle structure. When you put your color flow on the structure, you'll need to make sure that you turn the scale down to a low setting. Also remembering to turn the gain down, as this will make a lot of flash if you don't. When you do this, you'll be able to see that the structure is aliasing. That is where the ductus venosus is, where you see the aliasing. Now, steady as she goes, when trying to Doppler the ductus venosus, sometimes adjusting your gate size may be helpful, but it may also start to pick up other nearby vessels. So you have to be careful of how big you get your gate. Then other times you might have to have the mom hold her breath to get a really decent Doppler of this vessel. It's really tricky. Give yourself some time to get good at this. Remember, if you're just trying to learn this skill, try to find it on every baby until you feel comfortable finding it. Remember, it's 3 millimeters in length, so it's super tiny. Give yourself some grace. Later, this vessel becomes the ligament in the liver, ligament venosum. So after the baby's born and the cord is cut and things start to close off, that becomes a ligament. So just give yourself some grace. You'll be able to see it going into the right atrium of the heart. So know that the mother's breath, the baby's movement, or the baby's breathing, or mom's breath, all this will affect that 3 millimeter vessel. So you'll want to be able to control as much as you possibly can in order to get a really good, decent view of that. If that vessel shows a reverse of flow, then you know there's a high pressure in the right atrium. And that would be a sign of heart failure. So you're doing this to check to see how high if at all, the pressure is in that right atrium. Many times when we see reversal in this vessel, then we know that we're working with a very short time period of viability for this baby. This time period varies according to what study you're reading, but it's important to document and to share quickly with your physician when you find this. I will link in the show notes the studies that support this evidence on ductus venosus. If you have any questions, please message me. Thank you. That is the end of our podcast. Thank you for tuning in to It's All About the Frequency podcast. I hope you've enjoyed today's episode. Share it with a friend, and remember to keep your frequency high.